All right, so today we got a great episode in line for you guys. We're joined, actually, Justin and I are joined today by Dr. Michael Jurewicz and Dr. Omer Kineish, two fellow urologists. We consider them our good friends. And we're going to actually have a really cool roundtable discussion on all things testosterone, low testosterone, treatments, things that you should be concerned about. And we're just going to have a roundtable discussion, 4 perspectives here, 4 different urologists, and just kind of getting different perspectives. So, before we start, you guys know Justin and I. Why don't we have our fellow urologists introduce themselves?
Awesome. Well, thanks for having us on, Kevin and Justin. Michael Jurewicz. I live here in New York, Brooklyn, New York, practice in a private practice, big multi-specialty group. We have a bunch of different offices, but I cover the urology, especially the men's health. And, I love testosterone, love giving it out, love making people feel good. So I'm happy to talk about it here with you guys today.
All right.
Thanks a lot, Kevin. Justin, I appreciate you guys having me on this podcast. My name is Omer Kineish. I'm a urologist that's new to the Tampa area. I have a special interest in men's health. Hence, this is the reason we're having this podcast. I'm interested in having this conversation of testosterone and just educating everyone out there on, what it's about, and so thanks a lot for having me, and I'm looking forward to it.
All right, beautiful. So I think we're going to have a really engaging and great conversation, so your listeners are in for a treat. So the first question that I have for the panel is, how common is low testosterone?
I mean, I'll take this one. So low testosterone is extremely common. I think honestly, it's really underdiagnosed. I think statistics out there show that probably in 40 to 50-year-olds, it's like 40 or 50% of men have low testosterone, but I think that it's truly underdiagnosed, probably because men don't go to the doctor that often. They just sit there and struggle. They have weight gain. They don't feel good. They're tired. They have low libido. And they just, maybe think they're getting older or think they're stressed at work. And I mean, there's all different things that probably play a role, but I see it really commonly. Obviously, if they do make it into a urologist, then it's imperative to ask them, hey, what's going on? What are your symptoms like? What's your sex life like? And then as a basic part of our workup, we always check people's hormones. And again, I think I see it really common, especially I think it's getting more and more common in younger men for whatever reason. You're seeing it even in early 40s or late 30s, people with low to low normal testosterone, because I don't know if it's environmental factors. I don't know if it's related to diet, things that are going on, but we see it really, really common.
I mean, Justin, we've talked about it on previous episodes that, one, like Mike said, guys just don't want to go in to see doctors, right? I think there was, and then, on that part, that leads, testosterone and guys connected. I think there was one study that showed that almost 88% of men with low testosterone are not treated, which is pretty crazy. Okay, hard. What is insane, right? Hard to study. This is a paper that was published in, I think, 2006 or something like that. Hard to study these kind of things. But Justin, that's a crazy number, right?
I mean, it's a pretty wild situation where you have people who suffer in silence, right? And one of our colleagues always says that where men, we suffer in silence and we're not doing the things that we need to do to take care of ourselves. We're willing to do what's need to be done with our families, with our friends, with our jobs. And like Mokira says, they suffer in silence. Got to give them a shout out.
Shout out, Dr. Mokira.
Absolutely.
But on the prevalence, I think, and I've said this before, like Mike said, we're going to can probably see this as an issue. We've never been more unhealthy as a society. Obesity is running rampant. People have diabetes is increasing. We're more sedentary than ever. We're really not taking care of ourselves, and we're not eating healthy. We have now endocrine disrupting chemicals to deal with. These are things that we need to fix. And I think that by addressing our issues and going to see the doctor, can we fix these problems? But if we're sitting at home, sitting on the couch, eating shit, doing nothing, we're going to continue to see these prevalence rates rise. But yeah, about 20% of guys under the age of 40 these days may have low testosterone. And there's this idea of, andropause. Kevin, do you remember the number? Omar, do you guys remember the number? It's about 1% decline annually, correct? I think starting in your late 30s. So, this is something that most people will have a decline as they get older, even if they are treating themselves.
Yeah, I mean, it's definitely natural to have that decline. We definitely see that and treat accordingly in the older patients. But I also just think that we're underdiagnosing it. We're not seeing those patients. They're not coming in. They're, even if people are interested in, in their health, they're not seeking treatment for their testosterone, and they're not, talking to men's health specialists.
There's a lot of lifestyle things that you have to look at. There's so many things that we are doing in this day and age that could be affecting our testosterone. What Justin said and alluded to was kind of diet and nutrition, right? These days we may not have a balanced diet where we're not having adequate protein or healthy fats or carbs to help supplement our testosterone production. Another thing is exercise. We're living a more sedentary lifestyle. I'm a gamer, so I do like to play and sit down with video games. But, with lack of exercise, especially weight training or resistance training, you may not be maximizing your testosterone production. In addition, we do have in this country an alcohol and a substance abuse problem, and that can affect your testosterone levels drastically. When it comes to chronic alcohol use, that can affect your production of testosterone and even the signaling of your body to produce testosterone. In addition to chronic opioids or chronic marijuana use, it has been shown to decrease testosterone levels and also affect fertility. The other thing I'll tell you is as you get older, your testosterone levels tend to drop. So that is a factor that does happen over time. But like Justin and Mike have been saying, it just seems to be a problem that's happening earlier and earlier in our stages of life. And that's something that's interesting to see. One thing that a lot of people ask me is, how do I know I have low testosterone? What am I experiencing? How will I know this?
Yeah. So I think you bring up some really good points with lifestyle and lifestyle concerns. And I think that there's a lot of things that you also didn't mention that I think we need to bring up before we get to that next question. One of them is sleep. Now, I think that we all have had a terrible go at it, especially as doctors. There's a lot of data on people who lack good amounts of and its impact on your on testosterone levels. We know getting 7 to 8 hours is important because the testosterone levels in your body are in a circadian rhythm. They're highest in the morning, they're lower at night. When you're sleeping, you're kind of rejuvenating that and you're really getting back into rhythm. And we know the less sleep you have, you can directly impact your testosterone levels the next day. And especially if you're having chronic sleep issues, whether it's sleep apnea, whether you are in a job like we are, we see it in police officers, firemen, see it in veterans a lot. We see it in healthcare workers because we have high stress, poor sleep, and shift work things where we're sleeping at off hours, we're sleeping less, we're not getting the things we need to. And I think that is also a very, very important aspect of lifestyle that, really is starting to become to the forefront is the importance of sleep health. Now, I don't know, any other lifestyle factors that we can also incorporate here?
Yeah, Justin, you just mentioned it. Stress is a huge part in testosterone. As you get more stress, you have increased cortisol production, which is kind of your stress hormone in the body. And that inversely will decrease your testosterone levels. And so, having a stressful job or, like you said, lack of sleep, these are all things that can contribute to having a low testosterone level.
I always tell my patients, like, I'm gonna sound like your stereotypical doctor, right? I'm gonna be like, yo, eat healthy, get exercise, get good sleep. And you're like, oh, that's what damn doctors are going to keep. But there is truth to that madness because those are the basic foundational things that you need to be doing. And even look, if you put those things together and your testosterone is so low, that's where, medication, treatments, all that stuff. But I really, truly believe that foundation is very important. You got to invest in yourself. You got to do that for yourself. to make yourself better. And then, look, you may not even need treatment after that as long as you have those, core things taken care of. And sleep, Brian Johnson, I mean, he's on Twitter right now preaching that is the most important thing. That's maybe helping his nighttime erections. Who knows? But sleep is important.
I don't want to hear any more about him, to be honest.
I mean, the thing is that everyone now wears like some sleep monitor, sleep device, or a ring, Whoop, Apple Watch, whatever it is to track their sleep. And people are obsessed with their sleep. And I think that what we found, what friends of mine have told me, and I've like tried the Oura Ring before, and literally, if you have like one drink or two drinks, even like you think it's not affecting you, but you wake up and that Oura Ring tells you like, hey, dude, you slept like shit last night.
Yeah.
Even if you feel like you might have been well rested, which also is a bit of a catch-22 because like, did you sleep okay? Maybe you feel rested, but this ring is telling me, hey, you didn't sleep really good. And I think that people, actually, I think casual drinking is probably decreasing a little bit, but generally speaking, like drinking in general, it just affects your sleep so much. And as Justin was saying, testosterone has that diurnal rhythm. You need to rejuvenate yourself. You need to rebuild those levels. And it just, it's essential, and it really can affect your sleep.
Mike, that's the great thing about technology these days. We have such an access to our information, our data. All these smart gadgets, the Garmins, the Whoops, and the Oura Rings, they can measure your sleep. They can estimate your stress levels. They can measure your nutrition and how many steps you take. And, these are all important things that can help fix any issue.
Are any of these sponsors for our podcast? Did you hear that?
No, they should be.
Did you just hear that?
Because I'm
promo?
not going to say what I was going to say then, because I haven't tried
okay,
one.
All right, let's go. Justin, talk.
I haven't tried one. So I'm going to be honest. I haven't seen the benefits. And I personally, maybe old man yelling at a cloud right now, but I think that death by numbers, analysis paralysis includes all of this shit. I've literally had friends who are like, oh, I only got this many hours of sleep last night. I can't even go out because this says I need to go rest. I'm like, chill the fuck out. So I do also feel like it swings the other way, where it can create extra stress and extra problems.
Yeah.
But listen, it depends on like anything, how you use it and how you use your knowledge. But yeah, I hear both sides.
Yeah, I think it's true. Like you can go crazy wearing it. I don't wear it at night personally, but I've tried it before. Usually tried it on a night when I was drinking, so I obviously it didn't go well. It wasn't like, hey, dude, you did great last night. Good job, buddy.
Is that what you were looking for, though? You were like, hey, please just, give me
good sleep. Be good sleep. Validate.
Yeah, I was like, please show me it's not that bad for me. But no, it doesn't work out that way. So I wouldn't recommend making yourself crazy about it. And, adding to your stress level, which can reduce your testosterone level. So that's not recommended either. But yeah, I mean, data in the right amounts, in moderation, just like anything else.
All right, guys. So look, I'm gonna now reframe this question that Omar had asked to the panel. Now, how does a guy know that they're like, hey, I may have low testosterone?
Now, this is I'm going to take this one for a second, guys. Now, this is a great question, because the thing with low testosterone is that it can take signs and symptoms in different forms. Now, in general, when we look at the data, the strongest or most sensitive sign that you have low testosterone is a decrease in your libido or sex drive, okay? Now, that doesn't mean that if you don't have a decrease, or it doesn't mean that if you do have a decrease, you definitely do have low testosterone, but it is definitely a sign that you may want to go get checked. Other things that would point in the direction of you wanting to get your testosterone checked. One, being obese. Actually, I'll start off signs and symptoms, and I'll talk about pre-existing conditions. But signs and symptoms include low energy, low libido, as we discussed, breast development, mood changes, depression, bone health issues, osteoporosis, osteopenia, body hair loss. We're not talking about head hair loss. We'll address that later on. We're talking about chest hair, leg hair, and things of that sort. And those are some big signs and symptoms of things that should point you in the direction of having low testosterone. And other things include also erectile dysfunction, by the way. I forgot to mention that.
The most
I
important
know I
one.
missed
Just
a
kidding.
few.
Just kidding.
I missed a few. You guys, please feel free to chime in here.
I think you hit them up. Most
Yeah,
of them,
you got
right?
most of them. I mean, talked about fatigue, lack of energies, things like that, But really, I think that low libido, obviously, that's the main one that people notice first, I would say, that they normally come in for. I don't know. Some people say they have trouble concentrating or memory issues, things like that.
Right.
And also
Yeah,
poor sleep. Actually, poor sleep. People say they wake up, they don't feel rested. That can be a sign of sleep apnea. But I think there's also there's prerequisites or things that put you at higher risk for being low testosterone. And some of the guidelines recommend, being screened for low testosterone if you have these pre-existing things, right? We know that if you're obese, if you have diabetes, if you have HIV, if you have a history of cancer or have been treated for cancer, or both, obviously, you are at higher risk for having low testosterone. If you're concerned about your fertility, you should absolutely get, checked for testosterone. Doesn't mean we're going to give you testosterone for that one, but that is something that you need to address, because these are things that either put you at higher risk for having low testosterone or associated with lower testosterone. And therefore, as you can see, even having another condition may be worth getting you checked out, because these are compounding factors. Having low testosterone is related to heart disease, diabetes, high blood pressure. All of these things can compound into future health issues.
One other thing that I see a lot that we're screening patients for when they come in is for depression, honestly.
Mm-hmm.
So patients who are struggling with mental health things, either they're clinically diagnosed with depression or, they just have some mood instability or they just feel down a little bit, whatever it is. I think that if you screen someone and they're having some of those symptoms, and they do go hand in hand, maybe the patient is on SSRIs or they're in therapy or whatever it is, but they also, it may coincide, like I said, it may be related to low testosterone. Maybe they just were pointed in treatment with a therapist first, but really they should be pointed into treatment with a urologist. I think they can go hand in hand. So it's really important that we screen for those mental health things that are really prevalent in society now.
Yeah, Mike, I think screening is of paramount importance. It's not just your low sex drive or low libido and the erections. It's the stuff you just mentioned, depressive symptoms, mood changes. There are a lot of things that you have to screen to see if a patient is susceptible to having low testosterone. So I think that's a good point.
For sure. And I think, go ahead, Gav. Sorry.
No, I had a recent patient that came in and, I was like, why are you here? And he just basically said, look, man, and he was a young guy. He's like mid-30s. He's like, hey, look, I'm just not feeling like myself. Where I was a year ago, I just don't feel like myself. And I want to know what's wrong. So I was like, hey, have you had
it all the time.
Like, have you had your labs checked? He's like, no, I haven't seen a doctor in like years. And I just, I think it's something, related to being a guy. And of course, get testosterone checked and it's low. So, and I think Justin had mentioned that before, sometime before. He was like, hey, yeah, it's just like these guys, just like, just not feeling themselves. And that, I think, at its core, we listed all the signs and symptoms, but hey, if you're just feeling out of whack, it could be just the testosterone.
I think it's a great summary and a great explanation, because sometimes, you can't put your finger on it. You just know something's off, right? And no one knows you better than you. And the thing is, if you don't do shit about it, no one else can. So I think that is pretty much a summary of kind of what we're going with. But the one other thing I forgot to mention too is substance abuse. That reminded me when we were talking about these things, right? We still have an epidemic of, painkillers. We know that painkiller history usage puts you at a history of risk for low testosterone as well. So substance abuse is another thing. And we have a lot of people out there who have done the hard part and who have overcome those things, and they still feel like shit. Why? Because they probably have low testosterone. So these are other aspects of health where you've gone so far and you've done the harder parts. Same thing with cancer, right? Going through cancer sucks. You feel like shit during the process. Life with cancer, having cancer sucks. Life after cancer should not. And this is part of that process.
100%, totally agree.
So I think really naturally the next question becomes, we talked about all these predisposing things, the signs and symptoms of low testosterone, but does low testosterone have an impact on other aspects of my health?
I'll take this one. First off, I think you have to look at it like chicken egg thing, right? So, Justin talked about obesity, talked about diabetes. If you look at all the evidence out there, look at all the papers, low testosterone, keyword, is associated with increased chances of diabetes, increased chances of obesity. Now, the question is the obesity causing the low testosterone, or is the low testosterone causing obesity? That's where none of it's, it's kind of unclear. There's no clarity on that. But the importance is that there's an association. So that is, you have to put some credence to that there is some relation to that. And then one of the things they bundled us in is like the word metabolic syndrome. Metabolic syndrome relates to patients who have either obesity, high blood pressure, diabetes, things that put you at risk for potential for cardiovascular events. And what you're seeing is low testosterone is tied with an increased incidence of metabolic syndrome. Now, if you kind of carry that over more to cardiovascular risk, first off, a lot of people have this sense that if you're put on testosterone therapy, being put on it, you're actually putting yourself at risk for having increased cardiovascular events. That's not, I don't think that's, I think in the guidelines, they're saying that no one's know if that's for sure true or not, but there is pretty good evidence that show that if you have low testosterone, you look at the guys, overall mortality, overall cardiovascular mortality, it's increased. All right. And so those are the two main ones that I would say is important to look at: metabolic syndrome, cardiovascular risk, and also like the other things Justin said, downstream bone health. If you have low testosterone, your bone density is going to be a little worse. Sexual health and reproductive health. If you have low testosterone, you may have low spermatogenesis. You may be having troubles with conception. And so those are some of the things that come to my mind. I don't know if you guys have any other ones.
I think you hit on all the big ones. Obviously, I think that the cardiovascular and metabolic syndrome issue is the main one that I think about when, patient comes in, they have this chronically low testosterone and, they just they live like that. But in reality, we really should be pushing them to treatment a little bit. You don't want to push someone so hard and be like, you have to do this, but you definitely want to educate those patients that, even with a moderately low testosterone, you feel like, okay, maybe you don't feel yourself, maybe your libido's a little low, you're not sure about taking medication. But if you kind of explain it and frame it in a way that this could affect your cardiac health, your overall mortality, and maybe we should look at, maybe we don't have to give you, testosterone cypionate, maybe we can give you Clomid, maybe we can give you HCG, maybe we can give you something else that could just boost it a little bit and reduce that risk for you.
So on that note, we've kind of skipped it to...
Wait, I actually wanted to add something here.
All right. Go for it.
There was a couple other really interesting studies that are newer, now somewhat controversial, it's newer stuff, but there's actually data now suggesting, one, anyone, like you said, dying of younger age if you have low testosterone. Other considerations that you need to consider are things like, there was a paper that recently came out suggesting potentially, not saying 100%, higher risk of prostate cancer with low testosterone, higher risk of colon cancer with low testosterone, higher risk of endocrine cancers with low testosterone. Associations, not causations, but there has been literature that has recently come out in this regard that is very interesting. The other thing, when we talked about bone health, and I think this is very important in people, when I see and they're 75 plus and they're like, I feel fine, but I don't need to take any more medicines. I don't want to do any of this stuff. The recovery process for muscle, there's orthopedic papers showing that if you break your hip and you're and you have low testosterone, there's a higher risk of complications. There's
Yes.
a longer recovery in the process of, of that surgery. So orthopedic surgery recovery time is longer. Risk of complications are higher if you have poor bone health and you have low testosterone. Now, they're currently doing similar studies. A shout out to my colleagues at Northwestern who are doing studies, and they're investigating that as well in all surgeries, actually. So this is something that, I actually say is more preventative than anything. Making sure that your hormone levels are good, making sure that they're normal is preventing you from having future issues. It's potentially protecting you from being overweight, from having heart disease, from dying younger, and from having more complications down the line, because we all want to live a long, healthy life. If you ask anyone here, I am 100% sure, anyone, you don't want to live to 100 years old if you're going to be in a bed for 15 years, right? And this is part of that process, making sure that you're doing and feeling your best.
I think it goes with all the people who are really into longevity and, the whole trend is to be it goes back to having a lot of data, of course, like obsessing over your testosterone and really monitoring it to that note, like keeping it at a normal level is really important. And that we've seen that it improves longevity. So that's why those doctors or like the Brian Johnsons of the world are so obsessed with their testosterone. They're so obsessed with it because we've seen that it doesn't improve longevity. It reduces that cardiac risk long term. So it makes sense to track that closely and to supplement it however you want to supplement it. Obviously, you try to do things naturally, but if you can't, you need to supplement it so that you can live longer and healthier. It's about health span, not just lifespan.
So for our listeners who are now hey, I gotta make sure like I don't have low testosterone. Sharing to our listeners, so what does that workup look like? What's the workup look like for low testosterone?
I mean, in my practice, it's pretty simple. Obviously, it's main things that are related to blood tests. So that's your total testosterone, your free testosterone, LH, FSH, prolactin, estradiol. Some people get SHBG, sex hormone binding globulin. Main things, I mean, there's obviously lots of debate about what the levels are, and I think we can get into like what's considered low for your age or whatnot in terms of total T or free T. The LH and FSH are, assessing the pituitary function. Prolactin, also like looking at pituitary function and how that can feed back and affect overall testosterone production. And then estradiol is obviously important as testosterone gets converted into estrogen or estradiol. You look at, where is that level going to fall? Is it too high? Is it too low? Another thing, obviously, is just looking at doing an exam, like physically examining a patient, testicular size, hair growth, hair patterns, things like Justin was saying before, reduced hair growth in certain places or more hair growth is a sign of your testosterone level. So I think it's really important to just examine someone, see them, and their musculature. So, like, are they a bigger guy? Do they have more muscles or not? Muscle wasting would be another sign of low testosterone. So when I'm working someone up, blood tests are the first thing we go to. So you come in, you're definitely going to get your blood taken and then get a general physical exam. I don't know if anyone else does anything else differently.
Yeah, that's a good point, Mike. In addition to blood tests, I think that also, getting a really good history and getting to know the patient is very important. What type of medications are they on? Are they on some antidepressants? Are they on other medications that could be causing their testosterone to be low? What's their lifestyle like? Kind of getting a social history, getting a better idea about, what their life is like, just to give us any clues or signs if there's anything that needs to be adapted or changed, along with the blood tests, as you mentioned.
Omer, you're spot on there, right? And I want to tell listeners, what is hypogonadism, right? Is it defined as your testosterone is below, 300, below that number? And so that in itself means you're hypogonadal. Actually, if you look at the medical definition of it, it has to be accompanied with symptoms, right? And so like if you just got your testosterone checked because you're like, hey, I'm feeling great, I'm feeling awesome, I just want to know what my T is, and it happens to be below that, and you have none of the symptoms that we've listed, theoretically, you don't meet the definition of hypogonadism. Now, I'm going to throw this out to the panel. What do you guys think about that?
I think if you go back to the last, discussion we were having, the last topic about overall longevity, overall, different risk factors as it relates to low testosterone. That's just low testosterone. That's not the medical definition or the ICD code of hypogonadism. We're not talking about that. We're talking about, yes, I get it. There's symptoms involved and that have to qualify you as hypogonadal. But if we were just going to talk about low testosterone and how do we want to classify that and should we treat it or not? I think, yes, they are two separate things and you have to have symptoms to say someone has hypogonadism. But personally, I think that there is a lot of benefit to keeping people eugonadal at having normal testosterone levels.
That's such a loaded question, because, the textbook answer is what you explained. Just having those symptoms plus a low testosterone level below 300 is kind of that textbook definition on hypogonadism. However, every patient is different. And, the one thing I want to talk to you guys about is kind of figure out that range of testosterone amongst patients. Testosterone levels, if you look at it, can range anywhere from 3 up to 1,000. And so, the one thing you have to ask yourselves as physicians is, okay, which patient falls into which category of testosterone range? From what I understand is a younger patient, in their 20s into 30s, they can have testosterone levels that are normal to them in their, when they're 500, 600 range, and so when I look at a patient in their 20s or 30s and their testosterone level is 300 or 320 and they have the symptoms, that's something to think about if they need to be treated. Are we excluding them unfairly,
I think it's a great point. And I think that the bottom line is we're all humans, like you're saying, right? We can't live in a black and white world. We have to live on a spectrum. We have to treat each person as an individual. And going back to what Kevin said and combining kind of with what Omer said, a lot of guys, if you grew up feeling a certain way because you were always a certain way, maybe you don't know what it feels like to be normal. So I would argue that some people who have no complaints and feel normal don't know what actual normal is. So could a guy who comes in and says, my testosterone is 300, I'm a 30-year-old guy, I feel fine, and then you optimize him because he's technically at low T and he feels better and he's at a therapeutic range, right? 400-600, and you made a difference. Maybe you did do him a service there. He's feeling better and he's also, actually at a therapeutic range. Now, I'm also going to play devil's advocate to myself. You also have people, and we've also seen it, where you treat people who have low testosterone and they feel the exact same way when they get better.
All the time,
right? So this highlights kind of what Omer is saying. Every person's individual, everyone has their own range, and sometimes you don't really know what it is until you have that conversation with someone and you see where they're sitting, how they're responding to meds, what their lifestyles are. And you really have to do a good job catering these things, because I've seen it on both ways and we will continue to see it both ways. And humans are complex. We don't know what the fuck all these people, how they respond differently, but they do. And it's amazing. You give someone the same medicine, 1,000 people, they all respond differently.
Yep.
And that's the art of medicine. That is where the art of medicine comes in. It's not one size fits all.
Kevin, I'll tell you a story. When I first started practicing, I tried to go by the book and by the guidelines as to the T. And so when a young patient came to my office and, their testosterone level wasn't at that defined criteria below 300 and they had symptoms, I used to deny them. And looking back now from all the patients I've encountered and I've seen, you cannot fit each patient to one box. I don't know what your experience has been like, but that's been my experience as far as taking every patient with their own story.
I love that. I think that's where medicine should go. And maybe I've been impressed upon by Peter Attia in his book, when you're reading on it, it's like back, again, textbook answer. Like if a patient has symptoms, but their testosterone was 302. Oh, no, you're not getting testosterone. Well, so what are you doing? You're just waiting for that guy to get there and you're suffering and you're not preventing that from happening. You're just like, well, come back in 6 months. It's probably going to be 296. You're going to feel shittier and then we'll hook you up. Like, no, that's kind of the wrong way that we should be looking at medicine. And I think that's, I think all four of us kind of share that perspective, again, where looking at this differently. And I like the way you said it, Omar. Each patient's different, right? Has their own kind of nuanced kind of situation. So, yeah, I agree with you.
I look back and I think about those patients that I, did not offer them any type of treatment. And, I get concerned. Maybe they went somewhere else where they received care that was not as adequate, and they may have gotten even worse care as far as getting their testosterone replaced, in an unhealthy manner.
Yeah, I think that lends to the next question then, right? Who is a good candidate for TRT? I'm just going to answer my own question here because
Go for it, Justin. Please.
So I think the thing is, when we're talking about TRT, we have to understand several things. And I think before understanding who's a good candidate, you have to understand what TRT does to you to make sure that you are a good candidate, right? So the first most important thing is that testosterone causes infertility. It tells your brain when you take testosterone, it tells your brain you're making enough. So it stops the signal to your testicles to make sperm, make testosterone, so you can have testicle atrophy and sperm stops being made. So the longer you're on testosterone, the more dependent you are on it. And you can have infertility issues. So, the data shows about 60% of guys after only 4 months of being on TRT have zero sperm in their ejaculate. You can recover it after about a year, 90% recovery, about 2 years, almost 97, 99% recovery, but you're never going to get back necessarily to where you were before. And we don't know most people's baselines. So who's a good candidate then? People who no longer want to have kids. That's number one. And if you do want to have kids, we're going to talk about other options. Number two, people who have low testosterone and we diagnose as hypogonadal, right? I think that's actually a pretty important one. You'd be surprised, right? We did my secret shopper study where I was not a good candidate based off of my testosterone levels and my desire for fertility. I had testosterone levels of 675, and I think we can all agree here, even though there's a spectrum, I'm not a good candidate for TRT based off of that alone. Now, I was offered it by 6 to 7 clinics that I got to. So you have to have low testosterone. You have to have ideally signs and symptoms, but we've kind of discussed that as well already. You have to have no desire for fertility, future fertility. And then things like still controversy of prostate cancer. We're going to talk about that a little bit later, but in general, people with prostate cancer, probably it depends on what stage you're at and where you're doing it. But some people are not good candidates because of prostate cancer, while others may be potentially. Heart attack, stroke, you're fine. You really should be okay. And other than that, I think you're probably a good candidate for TRT. Am I missing anything? Who in your guys' minds is the ideal person for TRT?
Justin, I think you nailed it pretty well. I would just kind of piggyback on, patients who have, active prostate cancer, active breast cancer. Those are patients you definitely want to just kind of think hard about and have a discussion with those patients. The literature is not completely definite. However, there is gray area. So you definitely want to think about treating those patients with testosterone if they have active disease.
Yeah, the cardiovascular stuff, I think guidelines or, some papers would suggest like 3-6 months, from a recent event, you may want to kind of consider holding off before you get on it. But it's not like a you're never going to get on it ever. That's not the case. That there's some that would suggest that, look, if you got sleep apnea and you haven't had that adequately addressed, that's going to worsen it. If you're having peeing issues and it's getting close that you're not able to pee, then yeah, maybe the testosterone therapy may, data is all over, some urologists will say, some urologists will say it, some urologists won't. But again, that's a relative one. It depends on the urologist you're talking to.
So what you're referring to is does testosterone therapy enlarge your prostate?
No, we'll let Justin take that one.
You want to take that now, or we're going to do that later?
We'll talk about it later.
We'll talk
but
about
I
it
think
later.
that's what you're
Talk about it
alluding to.
Oh, and also, one of the things that we check as part of Workup is your hematocrit, right?
Yeah.
And so if your hematocrit, which is kind of like the viscosity, the thickness of your blood, if it's a little bit high, the percentage is high, generally above 50% or so. It doesn't mean you're not going to be able to go on testosterone therapy, but it means that, hey, maybe you need to go see a blood doctor, make sure that, hey, you don't have some sort of underlying condition, because you don't want your blood to get really thick, which can happen on testosterone therapy, and could put you at risk for something.
It's a great point. I have sent many a patient just to get checked by a hematologist, just as a CYA, just to like cover your patients, but to make sure that you're not making any additional risk factors. And once in a while, if you do screen the patients appropriately, they have some kind of hematological disorder going on, not necessarily cancer or anything, but you find some genetic thing that is important to at least identify. So there's a lot of things out there in considerations for thinking about TRT. And I guess, did we cover this, Kevin? But I want to be more succinct with this. Who is not a good candidate for TRT?
Well, basically just all the guys we just said right there, right? Just to kind of sum it up again, I think that Omar, Mike, and Justin mentioned, again, so prostate cancer, if it's active or suspected, you just talk to your urologist, right? I think we're really in an evolving time in this area, but I would just say you have to talk to a urologist on it. I have patients who are on quote unquote active surveillance, meaning that they have known low-grade, low-risk prostate cancer, but they're still on testosterone therapy, but under very close monitoring. So just because you have it doesn't mean you're going to be on it, but I think you have to talk to your urologist. It's a very nuanced thing. But like Omar said, men with breast cancer, very recent CV history. These are all things that I would say you just have to have a discussion with. And then, like Justin said, if you have reproductive years and you want to have kids, I think that's the most one at the forefront. You probably shouldn't be on exogenous testosterone therapy, but there are other options. But then, on the whole note of the elevated hematocrit, are there any other risks? Like, what are other big risks to taking testosterone therapy?
I mean, I think really the main risks, the main one that we worry about or we see often is what Justin said originally, is the risk of infertility. I think that's what we see so often in our offices, and I'm sure you guys see it all the time, that guys go get their testosterone checked, they go to the men's health clinic, somebody just prescribe, they're like, hey, yeah, you're not feeling good, here's some tea. They don't ask them if they care about their fertility, if they have kids, they want kids, how old are they? They don't even care. They just see, they walk in the door, hey, here's some tea, it doesn't even matter who they are, So I think the biggest risk, and the thing that if we could probably get anything out there from this podcast, is like, hey, if you take tea, it's going to make you infertile. So I think that's like the number one risk you should know about after hearing us have this discussion. Other things... Yeah, go ahead.
What's crazy, Mike? If we were having this conversation 15 to 20 years ago, it'd be a whole different ballgame. We would be saying, patients, you got to worry about their heart. Don't give it to them if they have a risk of heart disease or if they're at risk of prostate cancer. And so it's wonderful how the testosterone therapy space has evolved with evidence-based medicine telling us things and giving us data that can help support treating patients in a safe manner.
No, I think it's amazing that the research has shown, it's okay if someone is on active surveillance. I also have patients on active surveillance, and it's okay to give them testosterone. You definitely want to monitor them closely, but it's not like, hey, prostate cancer, no testosterone therapy. You don't have to be so black and white. So I think you're right, Omar. I think that's great. I think that, also the cardiovascular health that we've talked about a few times already is really important. It used to be like, if you give testosterone, someone's going to have a heart attack. It's like, no, that's really actually the opposite potentially. So, for so long, even, probably that's a pretty recent phenomenon. Pretty recent studies have shown that it's cardioprotective. So I think that those are really important things that research have shown. Yeah, I think overall just risks related are going to be that reduced fertility or infertility is the main one that I always tell patients, I'm always thinking about, because there's so many guys out there that they just have no idea about it.
Yeah, and I just want to piggyback off of that quickly, because some people, and I've seen this on social media, some companies are like, do you have to be off of TRT? Do you have to not take TRT if you want fertility? And then you have these people who are not doctors being like, well, I have a guy, he had 3 kids when he was on TRT. He's totally fine. It's like, who gives a shit, dude? That's one.
They're not his.
That's one person. That's not data. Right? We live in a world of data. We gave you numbers just now.
But Justin, I've seen one. I've seen one.
Yeah, exactly. No, and does it mean that every person's not going to be able to have kids? No. But do you want to be the person that comes to see us because you don't have kids, and then you've been wasting a year of your life you didn't know, or another 2 years trying to family plan, right? Like, people are having families at older ages. This is statistically true. And the longer it takes and the longer you start family planning, the harder it may be to actually have a child. Now, that doesn't mean it's going to be a problem for everyone, but it also could be a cost difference. While you're treating your testosterone now, you may get return of sperm to your ejaculate, but it may not be high enough to have a baby naturally. You may have to do IVF, which is really expensive, in case you didn't know. So, there's a lot of considerations. And when it comes to, treating yourself now, we're looking at the big picture, and we're treating you for now and the future, where, big picture things, TRT and testosterone improvement is important, but it has to be for the right patient. And then there's also alternatives out there.
Just to piggyback, Justin, I guess the next question, which I'll answer for myself, is, what are the alternatives of testosterone therapy? Sometimes patients, like you said, just aren't candidates for testosterone, or, they may not be ready for it at this stage of their lives. The one thing that you have to look at is, what can I do, with my lifestyle? So the number one thing is kind of figure out your lifestyle. You can, maximize your nutrition, eat a well-balanced diet, healthy fats, good source of protein, good source of carbohydrates. Now, the other thing is vitamins. A lot of patients may not be getting sufficient vitamins. The studies have shown that vitamin D, zinc, and magnesium will help in testosterone biosynthesis as well. So, having a good nutrition plan is helpful. Another thing that can be helpful is increasing your exercise regimen. The studies also show that resistance training, weight training can help boost your testosterone levels as well. So those are important things. Like you said before, earlier in this podcast, sleep. You got to get good sleep. Getting at least 8 hours of sleep is really important to help, maximize your testosterone levels. If you're doing all these things, that's great. However, maybe it's not enough. And so there are medications that you can take that can help boost your own body's production of testosterone. And so, there are 2 medications that come into mind. One medication, it's called HCG. That medication itself is an injection, and it can be taken once or twice a week. That will essentially boost your own body's production of testosterone naturally. And it's been shown to have good results for a lot of patients. The other medication that comes to mind is a medication called Clomid. Clomid is a medication you take by mouth. And what that does, it also helps kind of increase your testosterone levels by blocking estrogen receptors. And so that is also something that's helpful as well, that we give to patients, or offer to patients who are not really ready for testosterone. There are a few other medications that I want you guys to also talk about if you guys have anything in mind,
Well, I mean, one of the ones I do offer my patients, which is like, I guess you can say an isomer of clomiphene citrate, is N-clomiphene citrate. Again, acts very much in a similar manner. Some people may argue that there's different side effect profiles, but, really at the end of the day, they're both really kind of core similar molecules. So that's one of them.
Do you guys ever prescribe anastrozole to your patients, not just by itself?
I have, but it's a very rare situation. I typically do not. I'm not a big fan of anastrozole in general in terms of just treating. The idea, are we talking about this later? I don't even know. Should we just
talk about it?
Just talk about it.
So the idea of anastrozole really is how it works. I think, Omar, you mentioned it before. It prevents the conversion. It's an aromatase inhibitor. So it prevents the conversion of testosterone into estradiol in the periphery of your body. And it's usually seen in your fat cells, which is why, actually one of the reasons why obese people who have more fat cells have higher risk of low testosterone because their testosterone is converted into estrogen, gynecomastia, breast development, all of these things associated with higher testosterone, higher estradiol. But the thing is, 15 years ago, you would see any men's health clinic, any guy on any TRT, they would be all on anastrozole because this idea was man hormone, testosterone, woman hormone, estradiol. We are men, no estradiol, zero estrogen, man, as much testosterone as possible. And that was dumb. We didn't know. We sounded like cavemen because we were thinking like cavemen. But what we actually have discovered in the last 10 years is that, believe it or not, estrogen is important for men as well. Why do women develop health issues, bone health issues after menopause? Well, their estrogen levels drop. So we know that estrogen is important for bone health. And we've also learned that estrogen is important for libido. So typically, I try to preserve your estrogen levels. And one thing that we look at is you can have elevated estrogen levels, and that may be okay as long as you're not symptomatic, breast development, nipple sensitivity, because we're looking actually for a ratio. We're looking for a testosterone to estradiol ratio of 10 to 1. If it's greater than 10 to 1, great, you're good. If it's less, maybe we have to consider estradiol. I still tend to do it only if you're symptomatic. But because, naturally when you increase your testosterone, your estrogen level is going to go up based off of the simple fact that some of it's going to be converted to estradiol. Now, having said all of that, I do have several guys who are kind of symptomatic. I had one this month, actually. He was symptomatic, had low testosterone symptoms. However, his levels were 600, 650, and everything was normal except his estrogen. His T to E ratio was off. I started him on anastrozole, and he's actually felt better. So there are situations where you have to look at the numbers. You have to understand the situation. And maybe some other person would have given this guy testosterone, but his levels weren't indicated, and we went with the anastrozole route. So that's my comment on anastrozole in general.
I'm also not a big fan. Personally, I don't give it very often unless, I guess, again, that ratio is way out of whack. And sometimes the problem is that you get patients that come in that are obsessed with their estrogen level. They come in there, what's my estradiol level? And I'm like, dude, just relax, pump the brakes here. How are your symptoms? What's your testosterone level? Like, we don't have to just block it, and make that number go down. It's not going to make you feel better necessarily, could make you feel worse. And like, what is the benefit other than like, you're so obsessed with your estradiol level? You're kind of like living in that past caveman mentality of like, must be low, got to get the estrogen low. So I think that, again, sometimes it can be counterproductive, and it, like you said, it can worsen libido issues or things like that when we get so obsessed and people get so obsessed with it.
I want to ask you guys what your thoughts are with HCG and testosterone.
What do you mean?
As a combination therapy.
Oh, I use it.
Oh, yeah, I think it's good,
Now, who is a good candidate for HCG plus TRT?
Also, if you value your ball size, that's very important, right? So, look, what's HCG? HCG, again, if you want more detail, I think Justin and I one time sat down together 40 minutes just talked about all this stuff. But HCG is an analog that will act very similar to LH. And so it's basically telling your body to make testosterone. You inject yourself with it. Some people do it once a week. You can do it twice a week. You can do it up to 3 times a week. The whole idea is that you're just basically telling your brain, hey, look, hey, make some testosterone, tell your body to make it, and as a result, that testosterone production is being made in your testicles, and then so that will increase its size. This is supposed to kind of counteract the effects of exogenous testosterone, whether it be injections, topical, whatever you're getting. It's supposed to counteract that so that way it's not just full suppression, and then you kind of have what's called testicular atrophy, where your testicles get smaller. And so that's my main use case. I don't know if you guys have any other ones.
Yeah, I mean, I agree with you, Kev. Typically, I do like an HCG 500 units Monday, Wednesday, Friday. You can do it twice a week. It's really up to you. The one comment I agree. I think the best use of it is really for testicle size maintenance. Some people like the idea of just keeping it, which is totally fine. But I will say that, a lot of people especially in the community, are giving it as a way to preserve fertility in addition to giving TRT. Now, there is data that this works, but I can speak for myself, and I'm pretty sure everyone here, that there's no guarantee that it works, right? I have seen guys on it that have preserved their fertility. I have seen guys on it who have not. So once again, it goes back to this idea of what your real goal is. And I personally, unless it's like life, like they are like literally, you know, and you have these guys once in a while, completely burned out testicles who just cannot, their testosterone, if you give them HCG, stays at 50, and they just, you know, they're not functional and they need the HCG to preserve their fertility. But it's a rare situation. And why are they in that situation? Because they were on TRT in the first place and trying to preserve and didn't know to preserve their fertility. So, you know, I still am pretty adamant against HCG plus TRT, except in rare situations for fertility preservation. I agree with you guys. I think for testicle size preservation, it's pretty good.
Yeah, you know, Justin, I agree with that. You know, when you give a patient HCG with their testosterone to preserve fertility, I think the evidence is lacking, and you really don't have a clear answer for the patient. It's essentially a toss-up. You know, can I make kids with this therapy? It's hard to tell, and you know, for me, I tend to recommend not doing that type of technique. You know,
there's no data on it. There's just no good data on it. And I don't think it's
off
camera.
You know.
Justin and we discuss this all the time, and I'm fascinated. Like maybe someday down the road we can do these personalized trials to figure out whether this is true or not. But at current, there is just no data that says that works. There just isn't.
Yeah, I mean, maybe you do some trial where you're giving some really high dose HCG to try to preserve fertility, something crazy. I don't know, but again, it just, you know, doesn't really make sense, right?
Well, there's also better options too. You have other
practice,
options
it
that we
just
can.
doesn't make sense. Like I don't know. I don't do it personally. I don't have too many guys who are, you know, who have had really bad testicular atrophy unless they've been on TRT for a really long time. Again, those are the guys that they do need a little bit, but for the most part, it's like, you know, I wouldn't initiate that kind of a therapy with someone coming in. I wouldn't say like, hey, you're coming in for a workup. We talk to you. You have symptoms of low T. You have, you know, a low T on your labs, and then like, hey, yeah, I'm gonna start you on this combo therapy. Like, I don't know if anyone tries to sell that to someone. I think they should run to somebody else because that's just, you know, like that's not a good way to get things started.
Yeah, that can be the problem these days. You know, because you know everybody in the physician space has the opportunity to prescribe these medications we talked about, and a lot of times these physicians will practice medicine that is not evidence-based, and they may do these combination therapies that are not recommended nor supported.
Especially that and Clomid with TRT, which we're not going to get into. I think it really makes zero sense. You should never take Clomid with TRT. It just doesn't make sense. There's zero data. At least there's data on HCG, that some data that supports it. Zero data on Clomid and TRT. And clomiphene TRT, I think it's a waste.
Together. Now, separate on the whole cycling stuff. We're not going to talk about that now. That's different. But together, that's what Justin saw.
Correct. Yeah.
Well, look, we've talked a little bit about it earlier on. Let's kind of get back to just kind of like clarify to our listeners. Does TRT cause prostate cancer, and does it cause cardiovascular disease?
So yeah, I'll take this, and the answer is quite simply no. We know that testosterone does not cause prostate cancer. Like I said, there's some data, very new data that's not definitive, but suggests that having low testosterone may put you at risk for increased risk for prostate cancer. And, you know, I literally had a patient today, and like we said before, there's context. Now, we know that giving testosterone replacement therapy, if you go back and listen to our episode with Dr. Morgenthaler, which was a very popular episode. He talks about his exploration into the space of testosterone and prostate cancer. But more and more data is coming out showing that it is safe and it's not causing recurrence of prostate cancer in people who have been treated for prostate cancer, or metastatic disease or progression of prostate cancer in people who have prostate cancer and are on TRT. So, you know, I literally had a patient today message me, say, hey, thanks for, like, I diagnosed him for prostate cancer. He's going to get a prostatectomy. And he says, I'll reach out to you in 6 months based off of how it goes. and we'll get back on TRT. Obviously, there's extenuating circumstances there, but it depends on how the outcomes are. It depends on what the pathology shows. But, is it out of the question? No, it's not anymore. But if you spoke about this even 5 years ago, someone would have said you're going to murder someone. So it's a crazy shift in data. And as Omar said, the evidence-based data is really coming out now, showing that you can either have had prostate cancer or actively have prostate cancer, depending on the kind, and be treated for TRT. The other question, cardiovascular disease, I think we explored at length already. We know having low testosterone puts you at higher risk for cardiovascular disease, dying of cardiovascular disease, and dying at a younger age. The Transcend trial from New England Journal of Medicine had definitive randomized clinical trials that was published that showed it did not increase risk for cardiovascular events. So we know that this is safe. Guidelines, like Kevin said originally, do say that if you did have a heart attack or stroke in the last 3 to 6 months, maybe hold off for 3 to 6 months until that event is done and you've been treated adequately before starting. I've had a couple events where I have done that, but I have also had guys who had heart attacks, and the question was, do we continue on them on TRT? And my answer was always yes. And there's no guidelines against that either. This is it for initiating therapy. So yeah, overall, neither one should prevent you from having TRT if it's something you're interested in and you're a good candidate. However, the answer always is go talk with a specialist like ourselves, a urologist, someone who is trained in hormone replacement therapy.
Justin, this was a groundbreaking trial, this Traverse trial.
Oh, I said Transcend. I'm sorry.
Which was, it's all right. It starts with a T.
It transcended a lot of things.
Yeah. But no, this Traverse trial is groundbreaking for us in the world of testosterone. It gives us ammunition now to treat patients safely. And, when now a patient comes to me with low testosterone and he says, Doc, is this going to give me a heart attack? Is this give me a stroke? This is going to kill me? And I can confidently tell them, the evidence does not support any of that. It's quite safe. And then when it comes to prostate cancer, Doc, is this going to lead to prostate cancer? Or is this going to, enlarge my prostate to a degree where I'm going to have lower urinary tract symptoms? These are all answers I have the answer to where, fundamentally, no, you don't have these risks, In addition, this trial did show an improvement in mood and an improvement in bone and muscle density. So there are so many variables that we got and information that we got from this trial that helps us treat patients the right way and confidently tell them, you don't have those risks.
All right. So we kind of went into the options of alternatives to TRT, but what are the actual options you have if you are eligible? You're a good candidate for testosterone replacement therapy. So what are our options if you want to take testosterone replacement therapy?
I mean, for me, for my patients, I think the best option is the option they're going to use. So that could be,
I love that.
Whichever one is going to work for you in your life, you use it. So there are a few options. So just to list them, there's the gels, there's underarm stuff, there's injectables, so the injections daily, there's injections that are every, couple of months. There's oral medication. So it comes in all kinds of forms. But the main thing is that if you're symptomatic and you have low testosterone, whatever it is that fits into your routine that you can remember to do. So if you're a routine guy and you want to wake up and after your shower, you put the gel on your chest and you rub it around and you let it dry and you like that, go for it. I think patients don't usually stay on that and they don't have great results from that personally. I feel like my patients don't do well, but hey, I do have some that they love it, and it works great. But so that's one option. Some people, they can't stand needles and they want an oral medication. So there's oral medications out there, maybe it's a little more difficult. It's twice daily dosing. So maybe you forget, but hey, if you don't like needles, there's something for you, If you don't mind needles, but you don't like it that often, okay, you can have something that's like an oil that's no long acting. It stays and it kind of disperses in your skin or in your adipose tissue, your muscle over time. So that's an option for you. Or there's, of course, more frequent injections. So weekly, or some people these days even go for multiple times a week if they want to really titrate their dose. So I think there's a whole gamut that it runs the whole span of different options out there for patients, but it's really whatever works and what people will remember to take, because you really want to keep that, the level normal. And so just whatever works for the patient.
Episode 66. Just go tune into that. Mike's exactly right. It really is the way you want to get it. Oral was that missing component, and now in the past couple of years, we got that. So you got everything. Every option is out there. There's a lot of nuances to each. Again, we could spend hours talking about this. So just listen to episode 66. It really sums it up nicely. Each one has some pros and cons, with kind of how your levels go up, how your levels go down, how high the peaks are, how low the valleys are, and how often reality is for some of these pills. You're going to take them multiple times per day. So again, very nuanced into it, but you got every option. Every option is out there for you. The world is your oyster.
I think that one thing, though, is also important that you guys both are kind of alluding to is within this buffet of options, you're not locked in to one, right? So, Mike said, he was like, some guys, they start on the gel and it doesn't work for them. So I put them on an injection. Some people I've seen guys, they've been on gels for 10 years and all of a sudden they're like, I don't want to do gels anymore. Or they have a grandkid and they're like, I can't do gels anymore. And then you change them over to injections, or you change them into Testosterone, or you change them into orals. There's so many options and you're not stuck at one. So that's what's really nice. You have this buffet that you can go back to the buffet line and take whichever one you want at any time, as long as you're having the conversation with the appropriate provider.
I love your buffet analogy. That sums it up pretty well.
I thought I just saw pills. I saw needles, just all in a long line.
And an all-you-can-eat restaurant right in front of you.
In your guys' practice, what are you guys doing in terms of follow-up for these patients? How often are you getting labs on them? How often are you seeing them and adjusting and offering this buffet? If it's working, if it's not working, how often do you see them?
I could take this one. In general, if a patient starts testosterone replacement therapy, it's very important to check some labs, traditionally between 3 to 6 months. These labs include a complete blood count. We want to make sure that your blood's not getting too thick. It's called hematocrit. Another thing is we're going to check your liver function, just to make sure your liver enzymes are doing okay and they're not going out of whack. And then a lot of times I'll also get a PSA as well if you're at that age range where it needs to be screened and monitored. So I would say between 3 and 6 months is a very safe window where you can monitor patients who are on testosterone therapy properly. And, you can kind of change or alter things as needed, in that time span.
I think that's fair. Yeah.
Usually
in the beginning, maybe a little more often, maybe I'll check them in a month, see where they're at. If I just am initiating therapy, I want to see hey, did we get a good boost here? How you feeling? Also just check on their symptoms again. So in the beginning, I'll definitely see them more frequently until we get into that range where they're happy with how things are and I'm happy and I'm comfortable. And then definitely space it out to 3, or I usually do 3 every 3 months, just again, checking on symptoms, making sure there's no side effects. I know people will space it out longer, but for me, I just like to, be in touch with the patient because, again, these things, they change often. And, again, patients want to, you want to just be in touch with them.
I agree with you. I think that's totally reasonable. And when I started practicing, it was actually, I would follow up when I started a therapy about 6 weeks after with blood work after about a month. But what I found out as I did more of it was, when you're initiating therapy, it can take, as we all know, several months for them to really feel the full benefits. Yep. And I found myself having to bring them back twice really soon. And I said, what am I doing here? Give them the full 3 months. Let them get, used to the medication, get the medication, start taking it regularly, feel a pattern, and then get into that and see how they feel. So I agree. I think 3 months is really, the shortest amount of time you should probably be seeing these guys to really see how they're doing. And both of you I'm on the same page. If I'm making some adjustments, I'll probably want to see them again in 3 months. If, this is someone I'm starting to really feel that they're hitting stride, I'll consider going to 6 months for follow-up. But once again, it goes back to that individualized feel, how the patient's doing, how you feel that they're doing, and whether they're succeeding with their regimen.
The only thing I don't like to see is that sometimes if in the beginning, if you're initiating therapy and they're not having that, they're not seeing the benefit early enough, then I don't like to see them get discouraged. You don't want to not follow them initially after like the 6 weeks. I get what you're saying,
Yeah.
but I think that a lot of times, especially if you have a guy starting on a gel, then like you got to see them because you got to like talk to them. If they're not, if they don't have a good response, then I try to just switch them quickly.
That's fair. That's a great point. It's a great point.
Yeah, I don't like them to get discouraged. They're like, hey, you gave me, you told me that I needed this tea and like it sucks. It sucks, but man. I don't feel any different, and whatever. My labs are, like marginally better. And I'm like, no, dude, just come on. Like, let's talk about it. Hey, did Dr. Dubin, didn't you hear about this buffet? Like, I got other options for you, man. I got other options. So, like, yeah. So,
you definitely got to manage expectations to patients as well. You got to have that conversation with them within the first month of treatment. Like, hey, you're not going to be Superman. You're not going to go lift a building tomorrow. You're not going to get jacked and shredded immediately.
Because that is the expectation, though. A lot of people have.
Oh, yeah.
A lot of people have.
Oh, yeah. So you got to give them a pep talk. You may start feeling a little better. Your mood may improve. You may have a little more energy during the day. These are the little things that you can give patients some confidence on. But a conversation definitely needs to be had as far as what to expect, especially those first few months,
I couldn't agree more. I think setting expectations, especially with what we see in social media, who are they showing the people that are taking TRT? These fucking jacked out guys, right? These jacked up guys.
Ronnie Coleman
who probably
guys.
are like, don't need TRT in the first place. But the point is, I really like what Omer said, because the truth is, we've all had the patient. He comes in, his testosterone level is now goes from 250 to 750, and he feels better. But then he's like, I'm still fat as shit, and I'm still like overweight. Like, why am I not losing weight and gaining muscle? And then it goes back to what Omer said in the beginning: these lifestyle measures. Testosterone, and I tell this to my patients, is not God's gift to this earth. It is not going to do all the things for you. It's going to help you. And it's one thing we forgot to mention before, where, a lot of patients get discouraged because they go see a doctor, they have low testosterone, and the doctor goes, just go exercise more, lose weight. And it's like this catch-22 vicious cycle where it's like, no, they don't have the energy, they don't have the metabolism, they don't have the motivation because their testosterone's low. So the answer is actually you treat the testosterone to help them get the energy and motivation and metabolism to lose the weight. But then you get them there, and then some patients go, well, why am I not losing weight? And then I go, well, are you eating healthy? Are you going to the gym? And they're like, no, I'm doing the same thing. I'm like, okay, well, it's not going to change, right? It's just not going to change. And the other thing that I think is very, very important that we brought up briefly here is sleep apnea. I can't tell you how many patients I've said, you got to go, I think you have sleep apnea, go get a sleep study. They have low testosterone. They don't get the sleep study. And then we start them on testosterone. Their levels are great. They're feeling better in every way, except they're still tired. And I say, have you gotten the test? And they go, no. They go get the test. They have sleep apnea. They start the CPAP machine. They're good. Now, why is that? We know that sleep apnea is associated with low testosterone, but we also know that people who have low testosterone, if you treat their testosterone and they have sleep apnea, it can actually worsen for some people their sleep apnea. So if you're tired and your testosterone levels have improved and you're not listening to your doctor, this is where the professionals come in, right? We see the big picture here. We know the other associations. And that's something that I often struggle to get the patient to the sleep apnea doctor until that fourth 3-month visit, because they're still feeling like shit or they're still tired, even though their levels are optimized.
I won't tell you. Every time I'm like ready to bring up, like, I want to ask that question, like, hey, do you snore? I always know, I can tell the patient's like, yeah, but that's not my fucking problem.
Yeah.
Right? I was like ready. I'm like, yo, I know he's about, like, he wants to punch me in the face. I'll be like, yo, do you snore? He's like, yeah. He's like, hey, that might be a cause. He's like, no. But that's the truth, though. It is. Even like, sleep apnea causes a lot of urologic issues. It causes nocturia, and so
absolutely.
It's an important, very, very underdiagnosed, issue.
Also just quickly about sleep apnea, it's much easier to diagnose it nowadays. You don't have to go to a lab and fall asleep. They give you these little monitors that you sleep at home with. And after 2 days of it, they'll let you know if you got it or not, And so I actually went for myself for a sleep apnea study with my ENT buddy of mine. It was quick, it was easy, and I don't have it.
Hey, give him a shout out. He's been on the podcast. Give him a shout out.
Dr. Andrew Rivera. That's my
shout
man.
out to Dr. Rivera. He's been on the podcast. It was a very popular episode about sleeping and snoring. So check that out. Episode out. Any other final comments here?
I want to ask you guys as a group, I want you guys to be the myth busters. What are the myths, the misconceptions of testosterone, the things that you hear about, whether it's in social media or, just in your office? Any myths that come out to your mind?
Why don't we just cancel that part? Because Kevin says it's too long. It's an hour and 20 minutes. We can do that for another 30 minutes.
All right, cool.
Sorry. So mark that, Kev.
Hold on, let me mark that.
Mark it, and then, sorry. Yeah, I saw, I don't know, Omar, if you were looking. He did the save for next time comment.
Oh, no,
I
I
didn't
didn't see.
But Omar was so into the conversation.
I'm into it, man. I'm in it, son.
It's just too long. We're an hour and 20, and typically it should be under 45.
Yeah.
So I mean, we're fine with this. We're going to keep this the way it is. But
good job, guys.
Let's wrap it up.
We're not done. We got to sign off.
Give me a sec. Give me a second.
Okay.
So Kevin, lead us into the next part.
Yeah. All right, I'm going to mark it again.
Lead us into the conclusion.
Yeah. All right, guys. I think this has been a fabulous discussion, roundtable. It's been really great getting 4 perspectives to talk about testosterone. I think we're going to revisit this and try to do it again sometime in the near future again. But again, thanks so much to Mike and Omar for coming on and hanging out with Justin and I on the pod. And you guys have any final thoughts or anything that you want to leave off on?
Go talk to your doctor about low testosterone. Don't get your information from anywhere else. Go talk to your doctor.
Besides Dr. Dubin.
You guys are not alone. We're here. We will give you endless amounts of information. That's what we're here for. This is what we do.
Really well said. All right, guys, this was awesome.
Awesome, guys. Thanks so much.
As
Thank you,
always,
guys.
Thanks for listening. Please subscribe to our YouTube, Spotify, iTunes. Download, comment. You can comment on all these things. Always appreciate it. And, if you're listening on the YouTube, you got 4 beautiful men here. So you should be listening on the YouTube at least. So, children of the world kind of thing.
All right.
All right.
Amazing, guys. Thanks so much. Thanks for having us.
Bye-bye.
Take care.